So in 2019, the World Health Organization updated their guidelines in which they recommended preventative therapy for all household contacts, rifampicin-resistant TB household contacts after disease had been ruled out. And this included all high-risk household contacts, which includes children and adolescents with household exposure to rifampicin-resistant tuberculosis. Following this guideline update, the South African National Department of Health also endorsed these guidelines for post-exposure management for rifampicin-resistant TB. And these guidelines really mirrored what was indicated in the WHO guidelines, saying that all high-risk household contacts with exposure to rifampicin-resistant TB should be eligible to receive preventative therapy. Following these guideline updates at the end of 2019, unfortunately, the world was struck by the COVID-19 pandemic, and South Africa, including Khayelitsha, had quite a hard first wave of COVID-19, and the TB services were greatly impacted by the shifts required to address the ongoing COVID crisis. With reduced access to healthcare facilities, TB diagnoses, treatment initiation, and medication for individuals on treatment already, our team really fought for and advocated for the provision of TPT as an emergency response to COVID-19. In addition to the fact that we know that the provision and broader scale rollout of TPT is essential to meet the goals outlined in the NTB strategy. As with COVID, when COVID hit the Khayelitsha community, many different approaches were considered by the Department of Health in terms of reaching affected populations. And therefore, we had to think and strategize around how we provided services as well to re-engage individuals living with tuberculosis and their families who were affected by TB. And therefore, we had to adapt traditional approaches to the way in which we provided TPT to accommodate not only the ongoing COVID-19 pandemic, but to overcome the past challenges and barriers that I've previously mentioned that have been identified in providing post-exposure management services. So at the beginning of, around March 2020, the MSF team in Khayelitsha adapted their model of care and the approach by which post-exposure management was provided, and home-based care was provided for families in which an index case had rifampicin-resistant TB. So these home visits included doing an evaluation of TB signs and symptoms at the household level and providing linkage to care if disease was assumed for a contact. So contacts were booked for clinical assessment, and some contacts were assessed under this home-based model of care. However, due to some constraints, home-based care couldn't be provided for all households in which there was a rifampicin-resistant TB index case, so this was a differentiated model of care. So at the home assessment or the clinic assessment, what did this model include? Well, it included doing a clinical assessment, assessing that contact for signs and symptoms of TB, as I mentioned, taking a clinical weight, taking a TB history, doing a robust evaluation of whether there was previous preventative therapy received, doing the chest x-ray, which was really done at the discretion of the clinician. It was not routine for all contacts evaluated because this did require, if there was a home visit, referral to a healthcare facility, and it wasn't always required on the basis of the clinical assessment and the symptom screener that was done. And then in addition to that, expert testing, which was also done at the discretion of the clinician if there was presumption of TB disease. And we collected sputum, either sputum, gastric washing, or stool samples for testing with expert. So once all of these evaluations were done, the clinician, as a part of the home-based care team, would assess that contact for co-prevalent TB disease. And if prevalent TB disease was ruled out, that contact would be started on a 6-month course of tuberculosis preventative therapy. However, if a rifampicin-resistant or coprevalent TB disease was detected, then that individual would be linked into the routine healthcare service and started on treatment for disease. So the main modifications to our approach, as I mentioned, was really around the provision of care at home. So previously, asymptomatic contacts would have been recalled to the clinic for clinical consultation to do these evaluations. And as a part of this model of care, some contacts were assessed at home and referred to the clinic if further evaluation with chest X-ray and gene expert testing was required. Once treatment of infection was started, contacts were followed up telephonically at home, if there were available contact numbers, or a nurse would go back to the household to follow up. And there were multi-month medication refills provided to these individuals, so it didn't require them to go to the healthcare facility to get refills of their medication. And really, there was a comprehensive multidisciplinary team working to provide services. So the home-based care team included a nurse, a doctor, a patient support team, which had a peer supporter, a social auxiliary worker, and a counselor. So when need was identified, psychosocial need was identified, the family and the care for the family could be addressed in a more holistic, comprehensive manner. So to date, through this program, we've managed to identify 150 contacts, and 2 have been diagnosed with drug-sensitive TB disease, and 13 have been diagnosed with drug-resistant TB disease or rifampicin-resistant TB. Of the contacts not found to have TB disease, that was 135. They were considered as potentially eligible for TPT. And one of those individuals was referred to a different study that was going on in Khayelitsha. 15 contacts were assessed as either being initially lost to follow-up or not eligible due to the duration of exposure to the index case prior to the team being able to evaluate them, and 119, so 88%, were initiated on TPT. The majority of these individuals were started on monotherapy, with 81 starting levofloxacin tablets, 10 levofloxacin dispersible tablets, 3 levofloxacin syrup, 11 on INH, 7 on dolaminid, 4 on levofloxacin, INH, and ethambutol, 2 on linezolid, and 1 on rifampicin. So of the contacts that have been started on TPT to date, 74 have more than 6 months of follow-up time, and we have 61 of the 74 having successfully completed their course of preventative therapy, their 6-month course of preventative therapy, so that's an 82% completion rate. 11 of the contacts, 15%, have been lost to follow-up, and 2 discontinued TPT due to adverse events. So just to provide you with a little bit more information about the adverse events, in total in the cohort, 4 individuals have had adverse events, 2 with vomiting, 1 with diarrhea, and 1 with nausea. And all of these adverse events have been graded as grade 1, and none of them have been serious adverse events. Now, if we go back to the prior graph that I showed you up until 2017, here we see from 2020 to 2021, we really have had an increase in our case detection rates among those under the age of less than or equal to 18 years of age. And this can really be attributed to our efforts in ramping up post-exposure management for contacts with household exposure to rifampicin-resistant TB, in addition to other efforts that we've had towards decentralizing the management of pediatric drug-resistant TB and detecting drug-resistant TB in peds. So some of our successes with this model of care in terms of child and adolescent case detection is that we really have managed to find quite a high rate of co-prevalent TB disease detected via this post-exposure management, suggesting, as we already assume and as we know based on the WHO stats, that many cases in this population go undetected. And this has likely been, and the gaps have likely been exacerbated by COVID-19. One thing that we found is that actually the majority of the children and adolescents who were diagnosed with co-prevalent TB disease had very few symptoms of TB, and were mostly diagnosed on the basis of their chest X-ray, as well as the clinical evaluation. So this really does highlight the poor sensitivity of the existing screening and the need for robust clinical evaluation, including chest X-ray within this population. And providing this family-centered approach coupled with decentralized care at the household and community level has made it easier to interact with the population and address the prior barriers in access to care that we had identified. Success is linked to TPT implementation. We found that with COVID-19 and the perceived risk around becoming infected with COVID and the coinciding risks that exist between COVID-19 and TB, there was really a demand at the community level for preventative therapy, and families were more accepting of receiving TPT than previously found within our setting. The lockdown and school closures made it easier for us to interact with our population of interest, really suggesting that there's a great need for differentiated models of care to engage with this population. We found that because there were fewer visits required, clinical visits required for the families, having had received home-based care and home-based follow-ups or telephonic follow-ups, this led to time and money saving for the contacts and the families. And because these follow-up sessions were being done telephonically, it allowed for more frequent follow-up sessions where the providers and the contacts and families could develop a much better relationship without feeling time pressured. Finally, less time in the healthcare facilities led to differential health resource planning. So there were some challenges with our approach. Number one, seeing as how we did want to try to provide telephonic support and follow-up for individuals started on TPT. This wasn't possible for families with no cell phone numbers or if incorrect numbers were provided. So if that was the case, those individuals had to be referred to the clinics for follow-up. Initially, in the beginning of the COVID-19 pandemic, our providers went to the household level wearing scrubs, and this was viewed as not acceptable within the community, and therefore we had to rethink around what the MDT team wore when providing home-based care. Khayelitsha is unfortunately a community with high rates of crime, and in some areas there's more crime than others. So in areas where there was safety concerns, it wasn't always possible to be providing home-based care, so those families had to be referred to the clinics. And we did still have some challenges around perceptions and risks of TB infection and understanding around taking medication. Now, with that said, providing care at the household level and the frequent follow-ups with the telephonic support really did allow us to try to unpack those misconceptions or misunderstandings around TPT and address any questions that the family members might have when it came to taking the preventative therapy. And providing care at the household level really did highlight that the families that are impacted by TB have many complex social challenges in addition to their diagnosis of TB. And therefore, when dealing with this population, it is important to provide a holistic and comprehensive approach so that all of these social challenges can be addressed when providing tuberculosis care or preventative therapy. So my team recently published a paper on our response to our team recently published a paper in Lancet Child and Adolescent Health on the provision of TPT as an emergency response to COVID-19. And really, I think, highlighting our main successes, it's important to really think about differentiated models of care when dealing with this population, thinking about multi-month dispensing of preventative therapy, providing monotherapy, which allows for higher rates of treatment completion, completion, and providing telephonic support and follow-up for families that are getting preventative therapy. So in conclusion, we reported high rates of the detection of co-prevalent TB disease at baseline and very high TPT completion rates. We really attribute these successes to this family-centered strategy of household contact tracing, and providing care at the household level really ensured that individuals had the opportunity to be dealt with holistically and have opportunities to receive preventative therapy. Moving forward, we hope that other programs will learn from the lessons that we've shared and consider broad-scale TPT rollouts in order to prevent morbidity and mortality associated with all forms of TB and to align with the goals outlined in the NTB strategy. I'd like to thank my team involved in this work, and thank you so much, and I hope that this presentation was enlightening.